Good afternoon, everyone. Welcome to Medicine Grand Rounds. For those who don't know me, Michelle Chanchel, I'm the division head of renal diseases and hypertension. And today we're presenting one of our lectureships, that is the MATS Whalstrom Lectureship. First of all, I would like to thank MATS and Agneta that have really provided a major gift to the division in form of an endowment and in form of a lectureship. The endowment is used really to support the clinical research mission of the division, and the lectureship is really to support some invited speakers from across the country. And obviously today we're very lucky to have Dr. Catherine Tuttle as our visiting professor for the MATS Whalstrom Lectureship. Dr. Tuttle is currently as Executive Director for Research at Providence Health. This is in Spokane, Washington. She's also the Regional Principal Investigator of the Institute of Translational Health and a Professor of Medicine at the University of Washington. Dr. Tuttle received her medical degree and completed her internal medicine residency at Northwestern University in Chicago. And then she did 2 fellowships, one on endocrinology and metabolism at the Washington University in St. Louis, and then follow up with a nephrology fellowship at the University of Texas in San Antonio. Since I've been a fellow, I remember Dr. Tuttle. She has dedicated her career to chronic kidney disease, diabetic kidney disease, progression of kidney disease, and pretty much she has been funded her entire academic career. She has been editor of major renal journals, like the Clinical Journal of the American Society of Nephrology, as well as the American Journal of Kidney Diseases. She has received numerous honors and awards. 2 very important ones is the John Peters Award. It's probably one of the highest awards that is given by the Society of Nephrology to any investigator, and the Knoyan Award by the National Kidney Foundation. She has close to 400 publications, most of them in very high impact journals. And obviously, as I mentioned, dedicated her career to diabetic kidney disease. We are all for a treat because she's going to really give us a very nice summary of the novel treatments strategies that we have for kidney disease, both diabetic and non-diabetic kidney disease. So welcome, Kathy. Thank you for coming, and it's been a pleasure to have you.
Well, thank you very much for the kind introduction and really the privilege and pleasure to join you today. And big thanks to the Whalstrom family who support this lectureship. So my charge today is to tell you something else about GLP-1s. My title is Flowing into the Kidney. I will talk about the FLOW trial, but I'll also talk about the background of how now GLP-1 is transforming the field of nephrology, as well as so many other fields in medicine. Here are my disclosures, and the FLOW trial in particular was sponsored by Novo Nordisk. So the goal today will be to identify the scale and risks of chronic kidney disease and diabetes, discuss the evidence for GLP-1 receptor agonists for treatment of CKD in persons with type 2 diabetes, and then describe the emerging potential of GLP-1 receptor agonists to prevent or treat CKD in persons with or without diabetes. And when I got instructions for grand rounds in the CME, they asked me to start with a case. So this is a real person. Because we're no longer able to use pictures of our own patients, this is a persona, but I like to put a picture up because even though we'll talk about population level data, I'd like to remember that it's always really about a person. And then after I present the case, we'll go through the presentation and at the end come back with the learnings we've gathered in terms of how to implement some of these therapies for a person like this gentleman. So he's 42 years old. He's had type 2 diabetes since the age of 15. He also lives with obesity and hypertension, and he's been a lifelong resident of the Coeur d'Alene tribal community. You can see his medications there. He's on an ACE inhibitor, calcium channel blocker, a statin, metformin, already on empagliflozin, I should say, and insulin glargine, all once daily drugs. His blood pressure is 154/94 and his BMI is 40. And this is a typical referral to nephrology. His potassium's 4.8, creatinine's 3, so that gives us a GFR of 26, a urine albumin to creatinine ratio of 1,400 milligram per gram, an A1C of 8.2, LDL's 106, triglycerides 423. And even though he hasn't had a clinical event, he had a chest CT that showed incidental coronary calcification. So even without fancy biomarkers, just with basic clinical information, we can phenotype him as a person with type 2 diabetes, chronic kidney disease, stage 4, and atherosclerotic coronary heart disease. So I want you, as I go through the presentation, to think about how you might personalize heart and kidney protection, and at the end, I'll discuss what we did for him. So just to center you on the problem of CKD, it is a major public health problem. Estimates are nearly 850 million people in the world, 1 in 10 worldwide, but it's actually about 1 in 7 in the United States. And it is an increasingly common cause of death. And in fact, in 2019, worldwide, it was the 9th leading cause of death, and it's projected to go the 5th leading cause by 2040. These are studies from the Global Burden of Disease study published in The Lancet. Now, in the United States, the last estimates, believe it or not, come from 2017, and I did do a literature search on Monday. They still haven't updated these, but I would submit these are probably low ball estimates because we tend to be conservative. But in 2017, we had 40 million Americans and 85,000 deaths attributed to CKD. So while it hasn't received the public health attention of other highly fatal conditions, I want to point out to you that the problem with kidney disease is not just progression to kidney failure, it's actually mortality. I'd also like to center on the problem of diabetes as a starting point. So let's really think about the problem ahead of us. So these are now estimates from the International Diabetes Federation on prevalence of diabetes. This is circa 2021. These also have not been updated, but they've projected that by 2050, this number is going to grow to 1 billion. So for all of you interested in prevention, this is a huge problem, right? We know how to prevent diabetes, but it is not being implemented at a population level in any meaningful way. So while that remains the holy grail, and we do need to focus on diabetes prevention, the truth is that for the foreseeable future in our lifetimes, there are more people on the planet with diabetes. And living with diabetes means living with diabetes complications, still 4 of 10 with type 2 and 3 of 10 with type 1, making it responsible for half of all chronic kidney disease in the world, by far and away the most common cause. And while the traditional focus in chronic kidney disease is progression to kidney failure, what I really want to call out to you is the enormous competing risk of death. This is really a ragtag survivor band of just 10%. And it's not because they're doing well, it's because the majority of people will die, largely of cardiovascular complications, particularly heart failure and atherosclerotic heart disease. So when we talk about reducing risks, we need to consider the totality of risks. And the number one risk is mortality. This is actually a paper, it's currently with the Lancet and available in the preprint form. It's still in revision. But this is from our large Cure CKD registry. This is from our health system. This is an analysis of the competing risks of death and kidney failure and diabetes to further illustrate this point with specific data. So these were people who entered the healthcare system, and this is the overall diabetes population, death in black, kidney failure in red, and you see over the 10-year time frame, both risks increase. But death more than doubles the death risk is more than double that of the kidney failure risk. And then if we look by strata of GFR, greater than 90, 60 to 90, 45 to 60, we see that death and kidney failure rates continue to increase, but death still far outpaces a risk of kidney failure. However, when we get to what we would call CKD3B, GFR of 30 to 45, we see death equalizing with kidney failure. Again, this is a competing risk analysis, but this represents that the people susceptible to death have left. And it's only when the GFR is less than 30 that we see kidney failure far outpace risk of death. So the point is that both risks are important, but really until advanced stages of CKD, most people are going to die and not get kidney failure. So what can we do about it? Well, again, my focus today is really to dive into the GLP-1s. So I'm going to give you just a brief background on conventional therapies. So of course, we had the renin-angiotensin system inhibitors, which were our long-standing treatments of choice. But if you look at the old trials, the relative risk reductions with losartan or irbesartan were really very small and no benefit on mortality, only on kidney outcomes. Then, of course, we've had the plethora of SGLT2 inhibitor trials, which clearly have been game changers because on top of these therapies, we see an additional ratcheting down of residual risk, additional 30 to 40% relative risk reductions. But note that residual risk continues to accrue over time. So there's still substantial residual risk, even with SGLT2 inhibitors, or for that matter, even more so with the non-steroidal mineralocorticoid antagonist class, which has also come forth as one of our newer treatments. So that's where we enter the GLP-1 receptor agonists in terms of what more we can do, and particularly to address the totality of risk, not just the risk of kidney failure, but the cardiovascular and the mortality risks. So these drugs came to us through what we call the gift that keeps on giving, the cardiovascular outcome trials. And these were the result of the so-called rosiglitazone debacle in about 2006, when the drug was approved for use for glucose lowering, but there were a number of post-market approval reports to the US FDA of major cardiovascular events, and the initial focus was on atherosclerosis, atherosclerotic events. So that was the focus of these CVOTs. And not only did these trials, so the FDA then mandated, that if a new drug was put on the market for glucose lowering, starting in 2008, that the sponsor had to do an ongoing cardiovascular safety study to keep the drug on the market. And the design of the trials was such that if they were shown to be safe, that is non-inferior to placebo, then they could continue to test for superiority. And they really were a big win. We saw across the board, like with the SGLT2s, not only were they safe, but they were highly effective to reduce risks, particularly of myocardial infarction, stroke, and CV death. And two agents in the class, liraglutide in LEADER and semaglutide in PIONEER 6, had a cardiovascular death benefit in groups of people with type 2 diabetes, either with atherosclerotic heart disease or high risk. But the major secondary outcomes were kidney outcomes. And across the board, they decreased onset of macroalbuminuria. Remember, the most important thing is to ask who's in the study. So they were type 2 diabetes with CVD or high risk. So they weren't selected for kidney risk. Most did not have any kidney disease. So what can happen within the typical 2-year duration is onset of albuminuria particularly, and GFR decline to some extent. We will not see many kidney failure events in these trials because of who's in the trial and how short they were. But nevertheless, these benefits on the cardiovascular outcomes and chronic kidney disease were present even in the subset who snuck in with CKD, suggesting that this super high risk population may benefit at least as much as other people. The state of knowledge prior to the FLOW trial came from either post hoc or secondary analyses from the cardiovascular outcome trials and some glycemia trials. These are the kidney outcomes and a meta-analysis from the CVOTs circa 2021. And this is the kidney outcome, including albuminuria, so hazard ratio of 0.79 or relative risk reduction of 21%. Without albuminuria in the outcome, it was slightly attenuated, but again, most of the events are albuminuria events because of who's in the study and the short duration. So we shouldn't be dissuaded that this is only an albuminuria effect. And to further strengthen that argument, this is a post hoc analysis we did of 2 semaglutide trials, SUSTAIN 6 and PIONEER 6, where we looked at the subset of about 1,600 people who did sneak in with a low GFR between 30 and 60, and we looked at the effect on GFR slope during the observation period. So you can see they come in with a GFR here of 48, and semaglutide represented in blue, you essentially see stability where you see progressive decline in the placebo group and an estimated difference in GFR at 1 year of 1.06. And why that's important is if that difference in GFR is sustained for at least 2 years, it's highly predictive that the intervention will prevent kidney failure. And the threshold for that, we know from a variety of analyses done in many, many kidney trials, is this should be above 0.75. So this was well above the level that we would use to predict a benefit on the true clinical outcome of kidney failure. There's also a benefit in people with preserved GFR, but somewhat attenuated because they're not losing GFR so quickly. So if we go into another population, this was a glycemia study called Award 7 comparing dulaglutide to an active comparator, now insulin glargine, so glycemia is equalized, but selected for moderate to severe CKD, so the lowest GFR you see yet, 35. The insulin, in this group, people will be declining. And in this group, the insulin-treated people represented in green, of course, had a significant loss of kidney function over a year, whereas this was not observed with either higher or lower dose dulaglutide. And this is just the bar graph of the 26 and 52-week data, again, showing about what we would expect for this population, about not quite 3.5 mil per minute loss over 1 year that's essentially abrogated by dulaglutide. So it's not just an albuminuria effect. There was an effect on kidney function, and it was this data that brought us to this point. This was the FLOW trial. It was a randomized, placebo-controlled trial of people with type 2 diabetes and chronic kidney disease. I am not going to read to you the detailed entry criteria or the outcomes. You can see those for yourself. This is exactly or very similar to the previous trials done with SGLT2 inhibitors, for example. And it was a randomized, placebo-controlled trial. It was stopped early for clear positive efficacy. This is a very high bar to cross. Clinical trials are often stopped for futility or safety, but having been one of the designers of this trial, I will tell you we set the bar exceptionally high to stop early because this was the only trial. There were not 3 like there were with SGLT2. And we did not want to miss on a signal for either safety or efficacy. But we received notice from the Data Safety Monitoring Board on October 13th, 2023, that we should stop the trial because of clear evidence of benefit. So with consternation and hope, we stopped the trial. The hazard ratio for the primary outcome, this outcome was 0.76. The reason I have the tick boxes here, I will explain in more detail later. But we hierarchically tested what we called the confirmatory secondary outcomes, which are really important from a study design aspect and from a regulatory aspect. Meaning, if you went on the primary outcome and you went down the hierarchy, 1, it's a statistically valid conclusion that those outcomes were benefited, and 2, it's what gets into the drug label at the end of the day. This was a very high-risk group. With CKD, I will not again belabor all the details, just point out the baseline GFR, 47, UACR, almost 570, a large burden of background cardiovascular disease, as we would expect. 95% were on an ACE or an ARB, the standard of care. Remember, we started the trial in 2019. SGLT2 inhibitor use at baseline was about 16%, which is about what you would have expected in 2019. Hopefully it's gotten better, but they were a typical population with diabetes and CKD at the time of enrollment. So the hierarchical testing strategy was the primary outcome. It was a win. The next was GFR slope. It was a win. The next was MACE. And the final, all-cause mortality. It's the primary outcome. And I'd like to point out to you that this trial went a median of 3.6 years, and nearly 1 in 4 people had a primary outcome. 24% relative risk reduction, and because we stopped early, again, methodologically, it means you spend alpha, so the P boundary for statistical significance was dropped from 0.05 to 0.032, and we met that handily. These are the components of the primary outcome. I'd like to mention that these these individual components, we are not powered for these. We are only powered for the composite, and by stopping the study early, we lost some of that power, but we still see everything on the right side of the line. There's no statistical heterogeneity. And so we would conclude that overall there is a benefit on kidney outcomes as well as on cardiovascular death. Here's the GFR slope. Again, you might argue that we didn't need to do this, but we are also trying to build the data sets to show that if you achieve these slope differences, this is a reasonable surrogate for prevention of kidney failure. And if you want to say, well, they might have lost weight, it was only 4 kilograms on 92. This is not a weight loss study, and it was only the 1 milligram semaglutide dose. But concerns about bias with regard to serum creatinine due to weight loss were addressed by also showing the GFR slope by cystatin C. The difference at 2 years in GFR was almost 3.4 with cystatin C, and it was 3.3 with creatinine. So we do not think that these are biased estimates on the difference in GFR over time. Here's the cardiovascular event rates for MACE, and I will point out to you, you can look at SELECT and the other cardiovascular trials and see that the event rates meet or exceed people selected for cardiovascular disease, because who's the highest risk group for all this badness? People who have CKD and diabetes. And here, to me, is the most important and indisputable outcome, all-cause mortality. During this trial, 1 in 7 people died. We have a 20% reduction in all-cause mortality. That is really stunning for a highly fatal condition. And remember, this is why I belabored that the competing risk of kidney failure is death. So here we have a treatment that reduces death, that reduces major cardiovascular events, which is the other competing risk, and the kidney events. The number needed to treat to prevent one primary outcome over 3 years was 20, a MACE outcome 45, and death due to any cause of 39. Very reasonable numbers needed to treat. These are subgroup analyses. Again, I will not belabor them, but they're by age and sex and some metabolic characteristics, BMI, diabetes duration, A1C. Again, underpowered for these subgroups, but no statistical heterogeneity, suggesting that across demography and across weight and diabetes duration or control, we see similar benefits. Same if we look by levels of GFR or albuminuria from the less severe to the more severe stages of CKD, although most were very high risk, we stratify them by different levels of GFR and higher or lower albuminuria, still consistency, and also by background cardiovascular disease, whether it was atherosclerotic disease or heart failure. These data are currently under review at a major journal, but the other thing people have wanted to see is the time to event data by severity of CKD, in this case measured by GFR at baseline. So whether we look at people with the lowest GFRs, less than 30, to the highest GFRs, a few people greater than 60, again, the time to event analyses are all consistent. The other really important outcome here, of course, is heart failure. Many people consider, particularly preserved ejection heart failure, an adjacent condition to CKD, I think is the terminology. So this was a secondary outcome, but not on the hierarchy. These data were presented at the European Society of Cardiology and published in JACC about 4 months ago. This is the data on heart failure. Hazard ratio 0.73, and this is hospitalization or urgent visit or hospitalization for heart failure or cardiovascular death, which is the typical outcome for a heart failure trial, 27% relative risk reduction. The other thing that I think is really important here is if we break these out by heart failure events, including CV death or heart failure events alone, we still see benefits. But also in this population, while there's a lot of prevalent heart failure at baseline, we also have people without heart failure, and we find that we can actually prevent heart failure. Let's see if I can advance this. So here you go, even without heart failure at baseline, new cases, new heart failure events are reduced by a comparable amount, about 30%. So we even see prevention of heart failure in the CKD population, who's very high risk of developing heart failure if they don't already have it. So now let's turn to a non-diabetes population and say, what are we learning about GLP-1s outside of diabetes? So this is one of the first papers. This is from the SELECT trial. So this is now the higher dose of semaglutide, 2.4, the weight loss drug, and overweight or obesity with established ASCVD. So classic CVOT, except now moving into obesity and overweight as opposed to type 2 diabetes population. Main secondary outcome is kidney. There you can see time to first event. Again, very similar result to what we see in the diabetes population, except very few of them had CKD at baseline, only 1 in 5. So if you look at the individual components of the composite, most of it was driven by albuminuria reduction, but that's what we expect in the population who have very little CKD. Okay. So what else is new? I mean, we're already moving on with the Gs, right? So the next thing is the double Gs. And we got triples coming. But the first one out the chute has been tirzepatide. So this is a dual incretin agonist. It's a GLP-1 with GIP. So it stands for glucose-dependent insulinotropic polypeptide, not gastrointestinal peptide. So we know the GLP actions are in the pancreas and the central nervous system. And the GIP has particularly profound effects on the central nervous system and on the adipose tissue. So the original intent of adding GIP to GLP-1 was for metabolic benefits, to improve the glycemia and weight loss aspects of these agents. However, this is from SURPASS-4. We published this about 18 months ago. SURPASS-4 is a CVOT comparing insulin glargine to tirzepatide. And again, if we look at a composite kidney outcome, so it includes albuminuria as well as GFR decline and kidney failure events, we see a hazard ratio now ratcheted down to 0.58. Now, you cannot compare between trials, but the effect size is quite large. And again, individual components, mainly driven by albuminuria, but consider who's in the study here. That's what we expect in the CVOTs. But from the same paper, here's the albuminuria effect. So in this group of patients, albuminuria, as we would expect, goes up progressively, but it's essentially extinguished and actually reduced throughout a 2-year period. And here's the GFR trajectory. And you see that the GFR is also preserved after an initial dip, which may be a hemodynamic effect. So the latest thing with tirzepatide now is tirzepatide leaving diabetes. These data were just presented at the American Heart Association meeting and published last week in the New England Journal of Medicine by Milton Packer and colleagues. So now we take the double G, and it looks like SELECT, but we take the double G into obesity, and this time, though, not ASCVD, but heart failure preserved ejection fraction with heart failure events. So that's hospitalization, urgent visit, cardiovascular death. This trial was also stopped early for benefit. Hazard ratio on heart failure, 0.62. So we're really now starting to see these agents emerge, not only for ASCVD, but for heart failure, particularly preserved ejection fraction. But I was very heartened to also be at the meeting, and the other abstract they presented was on the kidney outcomes from the trial. So I wanted to point out who was in this study. This looks a little different than the ASCVD population. It's a heart failure population and people living with overweight or obesity. So they're coming in with a mean GFR of 55. The median UACR was normal, but 28% had what we would call microalbuminuria and 8% had macroalbuminuria. So at least a third who had elevated albuminuria. So some more baseline evidence of kidney disease. And very interesting, what you can see on the GFR trajectories here is that there's actually an increase in GFR by the end of the trial. And this holds up with cystatin C as well. And there's a profound reduction in albuminuria, really large reductions in albuminuria. So this is now pointing in the direction. Another tirzepatide study in a heart failure population, a little higher risk for CKD, as well as in the ASCVD population. So we're seeing those same signals now outside of diabetes in high-risk populations characterized by obesity for kidney protection. This weight issue comes up over and over again. This is from an analysis we did back to our Award 7 study, which was in the CKD population, but the baseline BMI here is like 32. And this is either by creatinine or cystatin C. We see no relationship between GFR change and weight. So while weight loss is certainly beneficial and it may have kidney benefits, the point that we're making is beyond weight loss, there is kidney protection. So how might that be happening? Well, there are GLP-1 receptors throughout the body, including the heart and kidney, and they've been demonstrated in preclinical models to have many favorable effects, particularly on reducing inflammation, oxidative stress, and even reducing activation of the renin-angiotensin system. But of course, there are receptors of GLP-1s all over the body. That's why they have such profound effects on metabolic parameters, as well as cardiovascular and kidney parameters. However, I will go a little deep into the kidney with you, even though this is an internal medicine audience, to say that the peculiar thing, though, is in the kidney, there aren't that many. They're predominantly in the preglomerular vasculature, so the inflowing artery, the afferent arteriole. There are a few in the proximal tubule. But why would we have such profound kidney protective effects when it's not weight loss and there aren't that many cells affected? So we really looked at this very closely in a number of preclinical models, and this is from one of our papers in Nature Reviews where they redraw your own pictures so beautifully, so I'm repurposing them. But I think it really illustrates what we've learned from the models, and this is in preclinical models of either type 1 or type 2 diabetes, where they've been kidney-related studies, and it's been different GLP-1s too, particularly liraglutide and semaglutide have been used in the studies. But what we need to recognize is that the kidney is affected in diabetes and in most forms of CKD in multiple compartments. So not just the glomerulus where albuminuria is generated, but also out here in the tubular interstitium where there's a profound inflammatory and fibrotic response. But the key to this is that not all the cells in the sick kidney are intrinsic cells. There are a number of immune invaders, particularly macrophages and T lymphocytes. And so it may be that it's the invading cells that are modulated. And we see in the models a real melting away of the inflammatory and fibrotic response and many fewer macrophages and tissue-based lymphocytes. And when those cells, when the GLP-1 receptor is engaged by one of the agonists at the cell level, and this is multiple cell types, but interestingly, immune cells are very responsive to modulation by GLP-1s. And it's a series of downstream effects, mostly mediated by activation of cyclic GMP. And this includes suppression of inflammatory signals, particularly NF-kappa B, which regulates a number of the inflammatory and cytokine signals that generate tissue-based inflammation, less programmed cell death or apoptosis, and then a real effect to suppress NADPH oxidase and stimulate heme oxygenase, which reduces the oxidative stress. So I know this is a clinical audience, but I think it's important to consider the biological plausibility and that this wasn't an accident. And weight loss is certainly important for people living with overweight and obesity. But even in people without overweight and obesity, there can be benefits. And in people who do have overweight and obesity, there's additional benefits beyond just the weight effect. And then back to the clinical scenario, before we return to our case, is this is certainly post hoc and exploratory, but are there signals in our clinical studies that we might be modulating inflammation and fibrosis at the systemic level or at the organ level? So in the Award 7 study, my favorite study of dulaglutide versus insulin, we looked at a serum marker of fibrosis, PRO-C6. It's a marker of collagen 3 formation. And then we looked at urine, which is an effluent from the kidney, so more, if you will, organ-based marker of collagen degradation, something called urine C3M. So if we look at the macroalbuminuric group, so this is going to be the highest risk group for losing kidney function, the levels of the fibrosis marker in blood were much higher, but they were mitigated by dulaglutide compared to insulin. And then the group overall, they were lower, but still we see mitigation of the systemic fibrosis marker. And then at the urine level, it goes the other way, meaning the patients with macroalbuminuria who got insulin had the lowest levels of the collagen degradation marker, and these were increased by this marker was increased by dulaglutide. And then overall, not as suppressed, but still see some benefit. And then the higher the fibrosis marker in blood, the lower the GFR, and the higher the collagen breakdown marker in urine, the higher the GFR. So this is totally post hoc and exploratory, but it helps us link the models to say there are signals in patients that look like it's going the right direction. So we begin to start to link mechanisms to clinical interventions. And I do think it's very important because we need to understand the biology in order to properly design and implement therapies and have some understanding of why it works, not just that it works. So what I'd like to conclude with before we get back to our MOC question is the tagline we've adopted for FLOW is that semaglutide saves kidneys, hearts, and lives. And this is important because CKD in people with type 2 diabetes is common, and I want to emphasize, and it's deadly. We have highly effective therapies that now reduce risk of kidney failure, cardiovascular events, and death, and semaglutide is one of them. And FLOW has established clearly that semaglutide presents major kidney outcomes, MACE, and death in this population. And we really now can say it's the fourth pillar, along with the renin-angiotensin system inhibitor, an SGLT2 inhibitor, and a non-steroidal MRA. And we say semaglutide because at least to date, it's the only GLP-1 that's been studied. And then I think what's really important for those of us who are clinicians is to recognize that low awareness, detection, and access to care, though, are the major barriers to people receiving life-saving therapies and really delivering on this promise. And so I think the next wave is really have to be a very focused approach on therapeutic implementation. And then we'll certainly need our partners who are experts in implementation science to help guide us and figure this out, because we really are at an inflection point in medicine where we can truly change, not only people with kidney disease. I would posit that this is a major advance in medicine and for human health. So let's go back to our patient. When all else fails, examine the patient. So I won't recap for you this man, but he's a person with type 2 diabetes, stage 4 CKD with high-level albuminuria and atherosclerotic cardiovascular disease, right? So if we risk stratify him, as we should with both albuminuria and GFR, he's right down here in the red hot box, treat and refer. So that's good. He had come from one of the Indian health clinics, and they had done a really good job, I think, of doing primary care-based therapy. They already had him on IMPA and good diabetes care, but he still could have benefited perhaps from a little better control of his metabolic risk. But be that as it may, they referred him, and that's our job to provide some feedback on some of those issues, right? And remember that this heat map, I like, even though it was published by KDIGO, a kidney guideline forming organization, we've really looked holistically at the risk. So this risk heat map is not only predicting very high risk for losing kidney function, kidney failure, but also the cardiovascular events. And you know that by just looking at him. So here's your MOC question. So how could his cardio-kidney metabolic care be optimized? Do you want to start semaglutide 1 milligram weekly and stop the metformin? Do you want to increase his insulin glargine to 4 units twice daily? Do you want to add another oral agent, glimepiride, because you can use it safely in CKD, 4 milligrams? Or do you want to get more intensive about it and do both the insulin and the glimepiride? So you can think about it for a minute, and then I'll show you what we decided to do. Well, you might imagine. Clearly in this era, this would be superior. And I want to point out another thing. Other countries might have different approaches, but as a safety measure, we do recommend that if the GFR is less than 30, metformin should be stopped. And he was clearly one of our, he could have been in FLOW, right? He's really one of our guys in the red hot heat map. So we would be hopeful that he might benefit similarly to FLOW patients. And this is just the FDA label reminding us about paying attention to metformin. Admittedly, lactic acidosis is rare, but when it happens, it's often fatal. And now that we have these highly effective therapies like GLP-1s, if people can access them, there's no reason to keep them on a therapy with with this kind of risk. And in fact, the ADA, AHA, and KDIGO guidelines now say metformin is optional, if only if needed. In people with heart or kidney disease, that SGLT2 should be first line. And metformin's first line for glycemia, but if you get them on an SGLT2, for example, it doesn't have to be given. It's not required as first line therapy anymore. And in our CKD populations, I think we really should just move away from using it for the most part. So then, but we're not done yet, right? Because our remit is not just one thing, it's the totality of risks. So what else would we like to do for this gentleman? Do we want to intensify his antihypertensive therapy and try to get him to a lower blood pressure, for example, 130/80 or less? Do we want to add aspirin and change him to a high intensity statin? Counsel him about lifestyle, activity, nutrition, weight? Or should we be doing all of it? Well, that one was pretty easy, right? And then again, going back to at least the KDIGO guidelines that really emphasize the importance of healthy lifestyle as a foundation. First-line therapies do now include SGLT2 as well as a renin-angiotensin system inhibitor. Now, this is from originally the diabetes guideline. The new general CKD guideline has been issued in the past year, and it's been extended to non-diabetes as well, and irrespective of albuminuria for both the kidney and the cardiovascular benefits. Metformin is still there if you need it, but you don't have to use it if you get to where you want to be with SGLT2. And then the importance of regular risk factor reassessment. I can't emphasize this enough. This is not one and done. And this includes not only conventional risk factors such as blood pressure and lipids and glucose, but really importantly, albuminuria and GFR, because that really influences what we call risk-based implementation. So for example, if a person has persistent albuminuria, and I didn't go through the detailed data on finerenone, but the guidelines tell us that that's when we would drop in finerenone. Or we might choose a GLP-1 if the bigger issue, like in our guy, was weight and atherosclerosis and diabetes as well as CKD. And again, this is complicated. It's different than we've practiced medicine, whether we're in internal medicine or family medicine or cardiology or nephrology or even endocrinology. But we didn't have these tools before. And we all have an opportunity to learn and evolve. And now we really have therapies that make a difference for a huge number of patients. So I'll stop there, and I'm happy to answer any of your questions.
Thank you so much. Questions? Yes. Wonderful presentation, Kathy.
That was a very nice talk. You made a great argument around the efficacy in terms of slowing the progression of renal disease. What about potential toxicities? I know we're hearing recently about the potential for ocular toxicity and maybe exacerbation of retinopathy, things like that.
Yeah, no, thanks for the question. And I gave you kind of the high level view, but we've extensively examined the safety data. In fact, I just presented a lot of that at the World Congress of Nephrology 2 weeks ago in New Delhi. We did eye exams, so there was no worsening of retinopathy in flow. And in the studies where retinopathy worsening was reported with semaglutide, it was in the glycemia lowering studies where we had a similar situation as we did in the early days of intensive insulin therapy, where they had the rapid decline in GFR. So I think we still need to keep an eye on that, but we were very reassured in flow with protocol-driven retinal exams that there was no increased risk of retinopathy progression. And our interpretation is it looks more like a glycemic effect and lines up with what we saw in the early days with intensifying insulin therapy. So that's the best answer I can give you now. I think the bigger thing that comes up is the GI side effects. And the mantra there is start low and go slow. But again, we reported this a couple weeks ago, and it'll come out in a safety paper. We did not see, so people with CKD advances, people have more nausea and GI upset. But the increased rate of nausea and GI upset was not more in the the advance, was not more than we would, it was the same regardless. Like it was like 3% higher, whether the GFR was low or high. So it's about what we would expect for the population and not exacerbated more. But now I have to go back to clinical practice. I've been using these agents for a long time, and at the point of care, I think the most important thing is start at the low dose and go slow. We usually, in the trial, we waited 4 weeks to titrate like from 0.25 to 0.5 of semaglutide. But if a person was still experiencing nausea, we delayed the titration. So that's what I would say. I think the biggest issue is the vomiting, even more than the constipation. Some people get diarrhea, but the vomiting is what makes people really sick. And there's some people who can get into trouble with fluid and electrolyte problems from vomiting. So we nephrologists are hyper vigilant about that. But I think just start low and go slow and titrate it to that individual's symptoms.
Thank you.
I'd like to hear from you more about the effect of the drug on the immune and inflammation pathway. And two is that what would be the use of this drug in organ transplant patients? Because many of them do have diabetes or glycemic control issue.
So those are great questions. The immune regulation by GLP-1s is an area of active investigation. There's a paper in Cell Metabolism from about a year ago from Dan Drucker's group that is actually demonstrated in a sepsis model. So this is giving LPS to mice, that the effect may be through the central nervous system in the hindbrain in opioid receptors and beta adrenergic receptors, such that there's less of a central nervous system mediated efferents through those pathways that then affect the spleen, and it reduces the generation of activated T lymphocytes and macrophages. And they showed in the mouse model that the lung injury was substantially attenuated, and it mapped directly to change in the regulation of macrophages and T lymphocytes. So I don't think we can answer it specifically, but that's really interesting to me, because another thing in Flow that's going to come out in JAMA pretty soon is we saw fewer COVID infections and fewer pneumonias with semaglutide treatment. So I think there is something about immune modulation that's good, not only for the heart and kidney, but maybe even protection from organ injury, say in the setting of sepsis. But now, I'm outside of CME, but you asked me about science. So there is emerging evidence, and it's not to say that there couldn't be direct effects like within these tissues, but the systemic effect may be largely mediated through the central nervous system effects of these drugs. And then back to organ transplant, I think that's a really great question, because with regard to kidney, but I think it's true of other solid organs, even when we control, if you will, the immune response, we still see fibrosis and inflammation that may be more innate than adaptive immunity. So it's a hypothesis, but I think it would be a very interesting idea to test these as, if you will, the safety net underneath our immunologic therapies. We know that ACEs and ARBs, for example, don't do much at all to preserve a kidney transplant. I don't know if these will, but based on the biology, it's a good idea to test.
Fascinating talk. And so maybe springboarding off that a little bit. So it worked in diabetes, and then pivoted it to obesity. And then, so are you looking at these now in other forms of kidney disease? And again, you raised immune modulatory. So would this work in connective tissue disease associated? Would this be something you would throw at patients after a contrast bolus and AI, something like that? It seems like if inflammation is our pathway, then you could extend it beyond.
Again, great questions. When we had nephrology grand rounds, we went into mechanisms a little deeper. I tried to not torture you all too much with physiology and immune system function. But, I think that we're already moving in that direction, right? So in the data I showed you from SELECT and SUMMIT, these are non-diabetic people who had either ASCVD or heart failure, where whatever was causing loss of kidney function, we couldn't attribute to diabetes, and we see less loss of kidney function, less albuminuria. I will tell you that there are clinical trials going on of tirzepatide and semaglutide. There's been one reported called the SMART study, which was semaglutide in people with obesity and CKD. But interestingly enough, it's published in Nature Medicine. They presented at ASN Kidney Week, and it just published full paper. But the causes of kidney disease weren't just obesity. Like, there are people in that group that had IgA nephropathy and other things, and they saw profound reduction in albuminuria and stabilization of GFR. But again, it's a short phase 2 study, so I can't tell you that it prevented kidney failure. But my view of this is that where these drugs are acting is in adaptive immunity, which is a final common pathway to organ injury, particularly kidney injury, but I don't want to go too far outside my lane, but I think it applies to other organs as well. And so I view these as the safety net therapies underneath your immunologic therapy. So for example, with lupus, I mean, we know people with lupus nephritis, that lupus can be in remission, but they still progress. And it's because the feed-forward cycles have been activated into inflammation and fibrosis that are no longer driven by the inciting immune cause. So I think along with ACEs and ARBs, and you could debate later whether we need really all those things. I think those are the safety net. You'll use and both. You use your immunologic therapy, and then you'll use these things because you'll get rid of the inciting factors and you get rid of the progression factors with these things that zero in on final common pathways.
Thanks, Kathy. That was really, really wonderful. It was great to hear all of this from your perspective specifically. So I got a question a couple of weeks ago about the use of semaglutide in patients with end-stage renal disease or on hemodialysis, and I realized that those patients were not studied, in these trials, but I wondered what your thoughts are on that, and then whether you think there's any potential benefit specifically for the cardiovascular events.
Great question. In FLOW, we did not stop semaglutide if people went on dialysis. And there's no signal, this is in the safety report that we're putting out, that they had any worse problems than anyone else. So it appears to be safe. We don't have enough cases to tell you that it's going to reduce cardiovascular events, but I think we're going to see trials move in that direction. The same thing can be said for SGLT2 inhibitors. And in the population with kidney failure, whether treated by dialysis or transplant, the label indication allows us to use them, as you know, as a diabetologist. They are very effective for glucose lowering, unlike any of the other agents. And when used without insulin, they don't cause hypoglycemia. It's one shot a week and not a bunch of pills. And honestly, again, other nephrologists weigh in here, but in the population that we treat with on dialysis or with a transplant, we have more obese patients. And more all the time. And on the dialysis population, it might help them get to a weight where they could be transplanted. And in the transplant population, we talked about potential for immune function, but even now, we can probably prevent post-transplant diabetes and all that weight gain. So the label allows us to do that, Cecilia. We don't have the outcome data, but for the practice of medicine, and you can say for the metabolic benefits, we already are there, I think. And, it'd be great if we could do a big outcomes trial. In the Netherlands, they're doing the renal life cycle trial. So that's for an SGLT2 inhibitor with CKD4 dialysis or transplant with cardiovascular outcomes for the people getting kidney replacement therapy, and for the CKD4/5 not dialyzed, they're also looking at kidney outcomes. So we'll start to get some of that data. But again, it opens up a whole new world of investigation and great questions. But back to what you said, I think in the practice of medicine, I personally use GLP-1s in people with kidney failure treated by dialysis or transplant. And I can do it based on the label, but I surreptitiously hope that it's benefiting them beyond just glucose and weight.
It's a two-part question. One is, do you know if semaglutide is covered by insurance in the non-diabetic population? And two, what are we going to do about the large number of uninsured patients who would benefit from this therapy?
These are some of our barriers, right? This is going to be part of the focus we all need to have on implementation. So first off, I can tell you that I think now it was 3 weeks ago, the FDA gave semaglutide the label. And it's the label for not only preventing loss of kidney function and kidney failure, but cardiovascular events and cardiovascular death. The EMA, the European Medicines Agency, gave it even broader label, including all-cause mortality, which is interesting to me because the EMA is usually more conservative. But in any case, it now has the label. So this is very recent news. I'm sure that our insurers are not necessarily caught up with that label change, but again, having that hierarchical testing and hitting all those outcomes really gave it a very broad indication. So one, this is why study design is so important, because if it had just gotten an indication for progression of CKD, it wouldn't be very exciting. But when you can say prevent kidney failure, prevent losing kidney function, cardiac events, cardiac death, it's a big deal. So we'll see what insurers do with it. And uninsured people, I agree with you. And right now, things are really in turmoil. And we all, I think, need to be part of the solution. I know Eli Lilly has a direct-to-consumer program now. They went head-to-head with the compounding pharmacies. I believe the cost, like a person has to have a prescription, and they go onto a website. And the last I heard, and Cecilia, you might know more about this than I do, it was $350 a month out of pocket, but that's less than, or that isn't that like matching the compounders, which, so people are trying to make steps in that direction, but it's not a problem solved yet. But we'll get there. I remember when losartan was expensive, so we'll get there.
Some of the recent observational studies have shown that a lot of people do discontinue these medications with rebound weight gain. Have you studied rebound effects on the kidney?
Yeah, we talked about this a little bit earlier. You know, for a lot of the trials we do, particularly like the phase 2 trials where we're looking more deeply at mechanisms, there's a washout period. The washout period has become very unpleasant for people because even within like 4 to 6 weeks, we see weight gain, but I'll also mention that so many of these people have heart failure. What I've seen happen is some people end up, because we've stopped diuretics and stuff, and then we stop the drug, you know, ending up being hospitalized with not only rebound fat gain, but heart failure. So I think that is an issue. And actually in newer trials we're doing now, we're going to open label extensions. We're not withdrawing them. People will stop them for various reasons. I mean, it can be the financial toxicity, which hopefully we can get over. But I do think this is an important issue, but it's not just GLP-1s. And we talked about this a little bit this morning. We have data out of our own sort of health system data set. We even see ACEs and ARBs drop off from 70% use to 40% use by 90 days. So we have a problem across the board with keeping people on organ protective therapies. And I think, you know, look into your own practice, but I see this a lot, like a drug will get stopped with a hospitalization or something and nobody thinks about restarting it. So I think it's not all patient factors. I think there's a lot of clinician factors too. If it gets stopped, like ask the patient, can we restart? Are you ready? But I do think when people come off these therapies, it can be difficult. We don't know how to taper. Again, now I'm going to go to practice of medicine. I never thought I would see this happen, but I've had a couple of advanced CKD patients who started getting really thin and sarcopenic, frankly. Not a lot, but, you know, a couple. So we stopped the semaglutide and their albuminuria went up very quickly. So I just restarted them back on 0.5 milligram and then everything got better again and they quit losing weight. But we're still learning this, but we will be learning that. So maybe what we need to do after a certain point is back off a little bit to keep people on therapy. I hope I've answered your question. There's not really a data-driven approach. It's all what we're experiencing and trying to figure out how to handle.
Kathy, thank you so much for a wonderful presentation and visit. Thank you. Thanks everyone for coming.